Great. Well, we'll jump right in because I think Sarah's set to go. So this presentation is on Access MHA, and Sarah Kipping is going to be our presenter for this one. And Sarah is a senior health system leader with experience advancing access flow, outpatient care, and regional mental health system transformation. She serves as Administrative Director of Access and Flow and Outpatient Services at Ontario Shores Centre for Mental Health Sciences, and as Regional Director for Access MHA in the East Region. Sarah's work focuses on improving coordinated access, strengthening integrated care pathways, advancing digital and measurement-based care, and supporting high-quality mental health and addiction services across hospital and community partners. So without further ado, I'll turn it over to you, Sarah. Thanks so much.
Thank you, Shannon. So I'm just going to share my screen, and please, similar to Beth, making sure I'm sharing the right screen as we go. Okay. People seeing my slides? Can you see them?
Yeah, it looks great.
Great. So thank you everyone for having us here today to talk about coordinated access, the provincial coordinated access model. So as Shannon mentioned, my name is Sarah Kipping. I am employed through Ontario Shores. Wear multiple hats in different areas and different initiatives of work. But one of my areas of initiatives is what's called Access MHA, which is the East Region's approach to provincial coordinated access for mental health and addictions across our region. So beginning in the Central East region in Durham, right through to the Champlain and Ottawa region as well. So happy to provide an update today. And as it was kind of mentioned earlier, it's a bit of the glue to the pieces across our system and how we're looking to enable coordinated access and working together collaboratively. So I will start. Oh, it's not going down. There we go. Okay, so for today, hoping to provide an update on or just awareness of what the provincial coordinated access model is intended to accomplish, what this means for what is called Access MHA, which is our East Region's model for coordinated access for mental health and addictions. And then we have some client cases to provide some context or examples of what this could look like. And just sharing some data at the very end about our referral numbers to date. Unfortunately, our clinical manager, Michelle, as we mentioned, Miller, couldn't join us today. I'll do my best. We were going to split the presentation, but I'll be answering or speaking to most of it and then answering questions. Either feel free during the chat or at the very end as well. Okay, so provincial coordinated access, where this comes from, I think this is very relevant, or most people would be familiar with, is that the province's mental health and addiction services vary greatly across the province, and they're not always well known, not integrated, and can vary regionally. Clients themselves don't always know where to go to get help, or not knowing what services are even available to them and how to navigate approaching these services. And then at the same time, we spoke about earlier, even with the psychiatry consults at Lakeridge, Ontario Shores, people can end up with multiple wait lists. They can end up with multiple different providers. And then part of that context is that they're ending up repeating their story again and again before receiving the needed treatment. And at the same time, it makes it really hard for a system to be able to know what the system demand is, what the actual wait lists are when people are on multiple wait lists, just trying to look around and find something that can help them. And then at the same time, they might also end up, on the wrong wait list and then waiting months and months and months, and then finally getting to that service and then realizing that's not what they're looking for, and then starting the process over and over again. So while there's been some approaches to coordinated access in the past, it hasn't been consistent across the province or the region, and it can be different in its scope and function, and it's not integrated. So this is where we're kind of looking to approach this with a coordinated model. The current state of accessing mental health and addiction services, you can see, is that people could go, there's multiple entry points, so people could go to the ED, specialist, family physician, community services, or even just within hospital. And then from there, they can receive multiple referrals to many different areas, just really trying to look and seek getting those people the help that they're looking for. So there's many access points, many wait lists, intakes at every door, fragmentation in their care and communication. And not a standardized approach. And then it's us both from a people perspective in trying to access care, and then it also really doesn't help the system in terms of where we want to focus efforts and resources for demand and capacity and decreasing wait time. So what the province is looking to do right now, I mentioned there were some different pockets of coordinated access throughout the 6 regions. So there's 6 regions for healthcare in Ontario. Our East region currently has 10 kind of informalized or different strategies for coordinated access. And the vision is for that to be one. So this is where we're looking to have that one front door for all community mental health and addiction services across their lifespan, where it's equitable, easy to navigate, and getting people to that right service at the right time for them. I think it's also important to identify what's the scope of coordinated access. So what is access versus care? So you can see in the gray box, this is really about how to get them into the front door, have a triage and a screening call for their level of priority or the level of need that they have. And then that triage clinician works with the client to match them to a service and send that referral to the matched service. And then from there, the client is booked to that service, and they're then on that service's wait list. What we do is information support. You can see we support all the management of the referrals. That triage call and that screening process happens. When we mention supports while waiting, we also always connect all clients to peer support, community peer support services while they are waiting for on the wait list for their intended service. And then using data to look at the system demand and the wait time. Then what we're not is obviously the actual care delivery. So we're not the assessment and care planning, the intervention or modeling. So this is we're that vehicle to help facilitate connecting a client to their appropriate service. So I think what it meant, even when Beth said it earlier, it's like we all don't need to know everything. That's what the front door of Access MHA is, even above and beyond Lake Ridge's Central Connect, which is amazing. An amazing model as to how to create this for the region, where if you feel your client needs mental health or addiction support, that you can refer them directly to Access MHA, and then we can help to match them to a service in the community. So where we are now with Access MHA, Access MHA is a regional model. It was actually stood up during the pandemic for supports while people were in the pandemic and isolated and needing and help in navigating the region. At the time, it was the Ottawa region. So the model began in the Champlain, Ottawa region, and then it grew and expanded into the Southeast region. And then we're in the final stages now of opening up into the Central East. So in the Champlain and the Southeast region, the model is currently live for both primary care referrals and for self-referrals. So we do both self-referral and primary care. Central East is currently open for primary care, and we are just getting ready to expand to self-referrals in July. So through this work, the province at the same time in developing the provincial coordinated access model formally adopted the OHRE's Ontario Health East region was formally adopted Access MHA as the coordinated access model for mental health and addictions in the East region. And Ontario Shores acts as the hub or the lead site for the East region for mental health and addictions coordinated access services. So it's been 2021, currently continuing to expand. So just celebrated our 5th year of being in service. Currently, Access MHA is for people that are 16 years of age or older. It is provincial coordinated access is intended, it is a lifespan approach, but there are also already coordinated access models for people under the age of 18. So what we do is we work with those coordinated access models currently to auto direct referrals to them like immediately. So this would be one call, one click as an example. So we work with our partners who serve the younger ages currently, and we'll develop that model together. This is all currently under development. We will work together to have that lifespan approach for our clients in our region. So it's anyone living in the East region. That could be what I mentioned before. So Durham, Central East, Southeast, and the Champlain. and it's at all levels of community. So this is not for inpatient referral. This would be for anything outpatient, not inpatient to hospital, it'd be anything for outpatients. So any type of mental health, substance use health, or addiction services, we can help to match people to those services. We give an example of what our client journey is. So starting at the referral on the left-hand side, you can see that we, like I mentioned, we can do self-referral. So the client can log onto our website, submit a referral, and book themselves right into a screening appointment. We also have a primary care provider referral pathway, which is through the Ocean platform to submit a referral. And then for all the services that are currently matched or onboarded, I would say, to Access MHA as a partner site, there are internal referrals to navigate clients to additional services as they might need them. So there's 3 different, as you could say, entry points right now for the referral process. And then from there, the client receives an email with an appointment information, and we use a number of tools to complete to help match clients to the right service. So they will receive those tools as well with the email, and they'll book their screening appointment. And then they receive a call for their appointment. They have a triage call with a clinician. If there's more information or if more assessment tools are needed, the staff will help them in completing that. And then they complete their standardized screening. And then following that screening and assessment process, they are matched to a service. And that service receives their referral. So we send the referral right to that service. And then we also have a process where if they self-referred and one of the services we think that they would be matched best to needs a primary care referral, we have a process with our team to help connect with the primary care to initiate or receive that referral so the client can be eligible for the service that needs that referral. And then they're also matched to, as I mentioned, a community peer support partner while they're waiting for support during that process. So I mentioned, so once the referral is sent to the receiving provider, they receive the package. Package contains the referral form, the screening information, the tools, the assessment, the relevant notes. We conduct the standard intake. The process is then at the service provider partners, SPP, complete the process, and they review the package, and they either say, yeah, this meets our eligibility criteria, or something might be missing. If it's a yes, they'll accept them to their wait list. If it's not, they'll send it back to us, and then we will complete that system service navigation or matching process to identify the right match. So currently, Access MHA, where do we refer to? So there's a range of options to meet client needs. There's, you heard about the Ontario Structured Psychotherapy Program before. Earlier today, we also have individual group counseling. There's psychiatric consults you can be matched to as well. Case management, substance use health, peer support, psychoeducational programs. We have a direct pathway for RAM clinics. If someone, based on the referral criteria, we can be auto-routed directly to RAM, bypassing that wait list for triage. And then withdrawal management and bed-based services. So of the, I don't know if it's on the next slide, I can't remember, but of the 73 current publicly funded mental health and addictions community services in the East region, we have onboarded, we're in the process of onboarding. We've onboarded 48 of them. And we have direct pathways to 278 different services for matching clients in the East region. So we partner with those publicly funded free services, like I mentioned. And what we do rely on is those services sharing with us. We go through a process together to create a service directory where we know what the inclusion and exclusion criteria are for each of those services, so we can make as many successful matches as possible. And we're at about 94% successful matches. And I went backwards by accident, I'm sorry. Okay, so I mentioned of the 278, we also do have additional pathways. So we do provide, there was some mention about crisis support in your offices. If you're in offices, we do offer some types of crisis support if we can, as Beth mentioned, depending on the level of severity. We do have additional pathways I mentioned, such as one call, one click, set up for auto routing to child and youth services. I also mentioned we have RAM pathway set up as well. And we do also service navigation for basic resources and needs. So if someone needs food bank, shelter, or transportation, we're happy to help connect people and connect them to those resources that they're requiring. So I mentioned also we do, so we don't change people's referral criteria. We use what people give us in terms of their information for criteria. But if there is a person who does self-refer and there is the need for a primary care referral, this is our process. I know we're sharing these slides after as well, that we can help facilitate getting that referral by faxing or working with your office to have that person either connected to a service that needs a referral if they didn't come with that already. So we do provide that support in the background. And what this is hoping to do is that people are no longer on multiple wait lists, like not having to shop around on their own, but that they're really connected and served in a way to match them to a service. And then, hopefully this can help people get service faster. So one of the intentions is really for this group here to make it easier for you to support your patients, to not have to know all the different services, be it Ontario Shores or Lakeridge or what that means, but that we can help. This provincial model can help as one starting point. So it's one referral you put in, there's one process, and then this team can help to match people to their mental health and addiction services across the entire region. So I mentioned it's through Ocean for primary care, and then we message back and forth through Ocean or outside of that for the outcome of your referrals and where people are matched to and keeping you in that communication. We completely appreciate that the voice of primary care is extremely important, and we would love to hear from you on an ongoing basis or any feedback that you do have for the continued success and growth of this. This will be provincially mandated that all services will be onboarded. So we're now in the phases of looking to do roadshows, webinars, attending your clinics, whatever you would find to be most helpful, so that we can get the word out that this is that one front door that can help you for mental health and addictions needs. We're looking for a primary care lead to support the work across the East region as well. And then we're now looking to leverage our OHT partners and our primary care networks to get the word out and to start to build and grow the model. We did have a few client cases or I think this is just one case that kind of walks through a number of different kind of examples. But this could be one where, so the person's name is Joe Smith in this example, but he submits a self-referral. His concern is wanting support with depression. So he goes and books his own appointment online, and he receives a call, the scheduled time of his appointment, and he speaks with one of the team members who completes the intake call. They then discuss different treatment options and looking at what they're eligible for. And then when Joe provides the consent, we would then route that referral package to the health service provider that they're indicated for in the community. What we do find is sometimes when a client first describes what their experience is, automatically sometimes it's the Ontario Structured Psychotherapy Program, which is that provincial program, or different counseling services that are there. But then there might be cases where someone describes, so in Joe's case, for example, he describes he is very heavily self-medicating with alcohol. And then the staff could shift the conversation to start a conversation around substance use health and exploring what their interest is in support with this. So it's really listening to the client, listening to what they're sharing, what their experience is, and then knowing, because sometimes substance use could be an exclusion criteria from a client for a different service that they may have been matched to. So really wanting to know their full story. So in this case, Joe visits his primary care physician and speaks about this. And then he submits the referral to Ocean. And then Access MHA receives the referral and looks into it further. Oh, sorry, this is an example when primary care is also involved. So there's different ways that Joe could be accessing Access MHA, either through self-referral or through a primary care referral. During the intake call in this example, Joe did share that he doesn't want to see a psychiatrist, but would prefer therapy before looking to try different medications. And then Access MHA would follow that client's wishes and most likely match them to Ontario Structured Psychotherapy or a different service, but not necessarily to psychiatry if that's not what the client is looking for. This is an example of, this is taken from one of the exclusion criteria. So one of our psychiatry consultation services does have exclusion criteria that we will follow. So the primary issue for this clinic must be mental illness. and excluding dementia, dual diagnosis with intellectual disability, primary alcohol and substance use disorder, or developmental delay or autism. And other exclusion criteria could be that they have community psychiatrists already, or they have access to psychiatry consultation services in their own catchment. So this is what the team really uses in their drop-down functions within the service directory to match people to the appropriate service. When we think of considerations that people make when making a referral, really just understanding what the client's needs are, what they're asking for, if they provide consent, knowing where they live, so we can, where possible, match them to a location that's closer to their home. Just understanding if they want virtual or in person, if they're able to do evenings and weekends for their appointments or not. There's been a bit of talk about this already today, but if people have private coverage or they need free services that don't require OHIP. And for psychiatry consults, there's some clinics that are curious about if people have seen a psychiatrist in the last 6 months, what trials of medications have happened, risk levels such as suicidality, if they've had suicide attempts, or what their diagnosis might be. So these are some of the questions that will come up when we're looking to do the match to a psychiatry consult. And then, just additionally, just wanting to know what other organizations are involved, if there's any legal involvement or probation conditions, is CAS involved, their risk level, substance use, willing to engage in treatment, cognition, and their willingness and, I guess, their ability to participate in treatment. And then I think just to wrap up the end of this presentation, I don't see questions in the chat yet, but feel free if there's any. We're just getting to the end here. This is a snapshot of the number of referrals that Access MHA has supported in the last year. So you can see in the entire program, we supported almost 18,000 referrals in the East region. You can notice that Central East, our region right now, is lowest because we're not open yet to self-referral. That is the highest demand that we do have in terms of referrals. I think now it's close to 81% is self-referral, which is great, in opening access. And since it launched in February of 2021, we've served 58,000, almost 58,000 clients, which is great to see that we're hoping to support that coordinated access and navigating people across services in the region. So hopefully that number will grow as we're now provincially mandated and continuing on the trend upwards and building and growing and onboarding partners. Looking forward to the work together. That is the end of the presentation that I had. So I don't know if there's any questions that anyone has right now or thoughts.
Just start by thanking you so much, Sarah. That was amazing. I think really, really needed, right? I think one of the burdens that we hear from primary care all the time is just how navigating patients to the right services and supports is really challenging and takes up a lot of their time. So knowing that there's this opportunity out there that will serve their patients in the best way and will make it the easiest for the providers themselves to send off those referrals, and the opportunity for self-referral too is really excellent as well. So thank you for this and all the work being done on that. And when you're ready to blast out and advertise in big ways, let me know and we'll help you out and get the word out as far as we can. And yeah, this is really, really great. So thank you. Any questions from the group before we let Sarah go?
I mean, it's even tangibly, we have posters, business cards. Like we love to come to offices, post those in waiting rooms and give people access that way as well. So however we can do that, if it's, driving around and stopping by or what that means, like we're happy to do that too.
Awesome. So great. Great. Thanks, Sarah. And then just to wrap up for the rest of the group today, please do complete the evaluation form. It helps us to know where we need to tweak these education sessions. As Joel mentioned, I think we're on number 5 or something like that. So we're starting to get them going. And so really do appreciate everybody's feedback as we do that. So I did put the link in the chat, and then if you want to use the QR code, it's on the screen right now. And then next month, so we are doing these in the last Friday of every month. we are doing these education sessions. And next month, I'm excited to share that we have 3 presentations again. The first one being advanced care planning discussion with Dr. Vince Ho. And then the one after that being understanding Faux Plus billing. How exciting is that topic? Everybody loves billing. So we do have Dr. Salish Bodo from the Ontario Medical Association District 6, that's a mouthful, coming to present on Faux Plus billing. So hopefully you'll get lots of questions answered there. And then some discussion around vascular surgery concerns with Dr. Brandon Van Asseldonk. So please join us the last Friday of June, which is the 26th. Again, same time, same bat channel, same bat place. And we'd love to see you there. So thanks so much for being with us today, and have yourselves a great weekend. Thanks, everybody.